Director for Born Ontario. I'd like to thank our first speaker today is Dr. Cliff Liebrecht, who's an associate professor at the University of Toronto, who's going to be talking to us today about increased risk for preterm birth and singleton pregnancies after blastocyst versus day 3 embryo transfer, the KN-ART register Carter analysis. And at the beginning, I'd like to just talk a little bit about the history of the relationship between Born Ontario and Carter. About a year and a half ago, Dr. Matt Geisler, who's the reproductive endocrinologist and the chief of staff at Credit Valley Hospital, approached me after a meeting we were together and said, hey, Born's done some fantastic work around pregnancy and birth outcomes. Do you think it would be possible for us to take some of the IVF data that's in Carter, link it to the outcomes in Born, and then have better outcomes for all, and also be able to, provide feedback to the centers like it's being done in Carter now? But one of the challenges, I think, was the follow-up of the pregnancies, because it had to be done by phone, and we already had all that information. So after a series of a lot of stakeholder engagement and working with Cliff and Matt and Al Uspe and Francois Bizonet, we've come with sort of a new and improved version of Carter called Carter Plus, which is for Ontario, linking the birth outcomes to the ART pregnancies. So we're very excited about that, and we're also very happy that Cliff can join us today. I've known Cliff since I was a fellow at U of T back in 98 to 2000. I think Cliff was probably just a junior staff at that time.
Yeah.
And Cliff is a remarkable guy in that he's one of those few people that can be an outstanding clinician and at the same time be an outstanding researcher, and he's been funded very well over his career and from prestigious organizations like CIHR. Cliff currently is a faculty member at U of T. He did his medical school and he did his fellowship in Toronto. Cliff, incidentally, is a medical legacy at U of T. I used to enjoy working with his dad, who was an obstetrician at Toronto General when I was there. He did his fellowship at the University of California, San Francisco, which he tells me he chose for the weather, not that it was the top unit in the world. He's a board-certified REI specialist, and he's currently working at Sunnybrook Health Science Center and Women's College Hospital in Toronto. He's the founder and the director of Create Fertility Center and the Create Cord Blood Bank. Dr. Liebrecht, as I mentioned, runs a research laboratory and is really an outstanding publication track record. He's well known in the Toronto community and is often on television and radio and in print. They ask his opinion on various international issues related to reproductive technologies. So without further ado, Cliff is a colleague and is a previous mentee. It gives me great pleasure to introduce you to the community in Ontario. Thank you.
Thank you very, very much, Mark. That was a nice introduction. And I just want to make sure everybody can hear me. Yeah.
Yeah, it sounds
okay,
good.
so I'm going to start the slideshow. If everyone can see that we're on the title slide, and you've heard already the title of the talk. So the objectives of our talk today is to review IVF. I know we have a lot of people here from various disciplines, so I want to start with some of the basics, otherwise the rest of the talk won't make much sense to some of you. And we're going to talk about some of the aspects of IVF and human embryologic development, and also some of the things related to why we use different culture systems versus blastocyst versus day 3, which you'll understand as we go along. We're going to review some studies that came out in the last really a few years looking at outcomes on blastocyst versus day 3 to show that there may be differences in outcome that might be important and could really lend itself to the Born database analysis in the future. Because our Carter database, which I'm going to present our study on related to the same topic, really had some limitations that didn't allow us to look in as great detail as we'd like to. We have a publication coming out on this, but we would really like to expand it and learn more about this area to understand what our findings mean. And I think Born will really help us, so that's the last objective, to discuss the significance of the findings and the potential for Born to determine the long-term significance in the future. So we're going to start off with Infertility 101. So infertility defined as 1 year of unprotected intercourse, and it's about 15% of all couples overall suffer from infertility. So most people know someone, about 1 in 6 couples, who are trying to conceive. However, this shows the graph of people attempting to conceive. In their first attempt, it's about 20-25% success. After 6 months, about 60% of couples will achieve a pregnancy, and about 85%, hence the 15% infertility rate after 1 year. Now, this is really related to an average age of about 35, where the rate of infertility is about 15%, but the rate of infertility changes significantly with age, and women that are older in their 40s have a much higher rate of infertility and difficulty conceiving, and it's a bit lower in younger age groups as well in comparison. The reason likely for this is that there is a progressive decline in what's called ovarian reserve with time, and this graph shows that decline, and it's a bimodal, bi-exponential decline. When you get to about 35, it's sort of all, I always say it's all downhill after that, unfortunately, but basically there's a progressive decline, and fertility rates really get low when women reach their 40s, hence one of our biggest challenges in fertility to try to help those couples have children. One of the other issues is not only do they have a decline in their fertility, but they also have more miscarriages. So they get pregnant, and their success at achieving a full-term pregnancy is reduced, and you can see here that you can have as high as 1 in 3 to 1 in 2 pregnancy losses when you're in your 40s and get older than that. And the reason for this is because oocytes decline in their quality in terms of their genetic ability to produce a baby because there's a much higher rate of abnormalities as women get older, and this shows the rate of Downs and other chromosomal abnormalities, and Mark in his practice would be very aware of this type of thing and those people that are doing prenatal diagnosis treatment. So when we talk about infertility, the other issue is what is the cause for a particular couple, and we divide it into the simple ovulation factor, tubal factor, cervical uterine factor, and endometriosis is sort of a category unto itself, and male factor. So these are how we work up couples' infertility, and we have, I won't go through the workup for that, that would be a whole lecture in itself, but we're going to talk just about some of the treatment options that really is related to what we're going to talk about today. So most people that conceive with treatment will go through the low-tech type of treatments we do, and we're luckily able to help those people conceive with the basic treatments, and that may just include things like counseling, surgery, medications, and sometimes artificial insemination. So these are kind of treatments that we start off in most cases. There are certain situations where we have to go to advanced technologies, but in many cases we can achieve pregnancies this way. Then we move on to the advanced technologies. And just before I keep going, can everybody hear me? Because I don't have any feedback here.
You sound good, Cliff.
Thank you. Okay, great. Okay, so moving on, this is the advanced reproductive technology list. And basically IVF, everybody's, I'm sure, heard of, and IVF with ICSI, which I'll talk about and show a little video on. And we have third-party reproduction, which are the different donation type of things, oocyte, sperm, and egg donation, and using a surrogate to have a baby is another third-party type of assisted advanced reproductive technology. Interestingly, we have one of the lowest rates of IVF in the world, actually, at least in the advanced countries. And the reason for that, probably in this graph, you can see that some of the countries of Europe, Scandinavia, and so on, have much higher rates, and it's likely because these countries have, simply, they have the expenses of the treatments are paid for. by the government, and we don't have that yet, except in one province in Quebec, where the rate of IVF has increased significantly, because one of the impediments, unfortunately, to doing these treatments is the cost, and it's unfortunate. It also, in our country, of course, there are vast distances between healthcare sites, and so there's also an access issue for our country in terms of IVF. But this is just an interesting slide, and I think there's a little problem with the slide here, but you can get the idea. So IVF, why do we do IVF in couples? Block tubes was the original indication, and now there are many, many more indications for IVF, including endometriosis. Sperm problems has come about because now we can do various treatments to help fertilization when there are sperm issues. Fertilization problems, again, we can help with, and some of the third-party reproduction. So we really now have many more indications than when it first came out in terms of Louise Brown getting pregnant because her tubes were blocked. Okay, so moving on, this is, I'm going to just show a little video of how we actually go about doing IVF, and I'm just going to do an escape here to go to my videos. So I hope everybody can see this here. So I'm going to show just what a retrieval looks like on an ultrasound. Can everybody see that now? Coming up, I think, now here. Can anybody see the video? Oh, there it comes. Now I can see it. Okay. So this shows an ultrasound view of the ovary, and the linear white object is a needle coming from the vagina into the ovary, and it goes into a follicle where you can see the follicles collapsing, and that's how we aspirate eggs from the follicle, and we go from one follicle to another. I call it the shish kebab technique. It's kind of you're able to sort of go from one follicle to another without actually withdrawing the needle from the ovary. And this technique is done under conscious sedation. We don't have to give general anesthesia anymore for oocyte retrieval, so it's a very simple process done in an operating room in a clinic. Okay, so I'm going to turn off that video and go back to the talk. And so hopefully, I think there's a little delay here. Okay, so now this is what the next slide, which is coming up in a second here, is the slide that shows the eggs. You can see this is what oocytes look like, and the surrounding part of the egg is called the zona pellucida. The next slide shows when we fertilize the egg. I think there's a little delay here. Here it is. And this just shows the natural type of fertilization, well, not natural, but the in vitro fertilization when we simply mix eggs with sperm together, and one of those spermatozoa will fertilize an egg in vitro to create an embryo. The other way that we fertilize eggs to help people get pregnant is another video that I'm going to show now, and this is a video on something called ICSI, or intracytoplasmic sperm injection. That video is going to come up in a second here. Okay, so I think everybody can now see the video, and it shows a pipette which is going into the oocyte, and it has a sperm within it, and that sperm is then injected directly into the egg. And this is an incredible technology that has developed over the last 15 to 18 years, which allows us now to create pregnancies when men have virtually, less sperm and their wives have eggs, and we can use a single sperm to inject into an egg and create a pregnancy. We can also extract sperm from the epididymis that doesn't even show up in an ejaculate if there's a blockage, and we can actually take testicular tissue and extract sperm that hasn't even developed into a mature sperm and create pregnancies with that. So this technique has revolutionized IVF over the years. So I just wanted to show that video. Okay, so moving back to the presentation, the next thing that happens during in vitro is fertilization, and this shows an egg that has fertilized with the two pronuclei from the egg and the sperm that have merged together and will then create an embryo. And these are the two pronuclei you can see in the screen here. Following this stage, the embryo then goes to the divides, and now you can see what a two-cell embryo looks like with the two identical cells that are divided. And each one of these cells could theoretically produce a baby, and it's at this point where identical twins may occur, where there's a split of the egg and these two cells divide and each create a new identical baby. Moving on to the next stage, which is after about 48 hours of development. This is called the 2 to 4 cell stage, and at this stage we used to do many of our transfers, but because we now have better technology for growing embryos, we can now grow them to a further stage. And so the most common stage of development for transfer is the next stage, which is at about 72 hours post retrieval, and this is usually when embryos are around 5 to 10 cells, ideally around 8 to 9 cell embryo. This is kind of an ideal looking embryo where all the cells look nice and are even and equal and so on. And this is the stage where we call the cleavage stage. So when I'll be referring to that in the talk, this is the stage where the embryos are being transferred. And in the world, this is by far still the most common stage of development when transfers occur. In the last number of years, we've gotten better at growing embryos in vitro because of better culture systems and incubators and so on. And now we can grow embryos to the 5-day stage, which is called the blastocyst stage. So on the next picture, you'll see a blastocyst. I think it's coming up in a second here. A little bit of a delay. Should be coming up any second now. I think it's just loading. So the blastocyst stage is when an embryo has now started to develop into what's called the inner cell mass and the trophectoderm, or external part of the embryo, where that will form the placenta. So I'm sorry, but it's taking a little bit long to load this, so I don't think you can see the blastocyst on your screen yet, but it should come up any second now. This stage is what we're going to be comparing to the next stage, the day 5 stage, or day 6. Sometimes we grow the embryo to day 6, and at that stage we get, there we go, there's the blastocyst. So you can see the thicker part of where there are multicellular area over here. I don't know if you can see my pointer, but that's where the inner cell mass that creates the baby, and the external cells around it create the placenta. And this embryo then has been grown for 5 to 6 days in vitro and is the stage that we'll call the blastocyst stage. So the next slide shows what happens to the blastocyst after it hatches. So the outer coating opens up and the embryo hatches out of that zona pellucida, and that's when implantation into the uterus occurs. So this stage happens sometimes prior to transfer and usually after transfer of the embryo to the uterus. The embryo is transferred by ultrasound guidance, and just for the sake of time, I'll skip that video, but it just shows an embryo being transferred into the uterus by ultrasound guidance. We place the embryo directly into the uterus at a specific location in order to optimize implantation. So ideal outcome from IVF is one healthy baby. I don't think we always believed that in the past, because I think we didn't understand as much as we do nowadays the risk of multiple pregnancies, and we used to think, wow, you have twins and everything's great, you're going to have your whole family at one time. But I think now we realize that that's quite a risky proposition, and so I think all ART and Perinatologists have come to the realization that this is the ideal outcome for ART. Multiple pregnancy, of course, has higher risk, especially higher order multiples, which nowadays are much, much lower than in the past. And we know, of course, that prematurity is increased, which results in numerous issues for babies, including neurologic and pulmonary, etc. And, of course, maternal morbidity is increased, and I don't have to tell all of the perinatologists on the line about these issues of multiple birth. I guess maybe multiple birth may not be so bad for some people. This just shows me being cloned, which I'd love to be. I am a pretty busy guy, and I wish I was able to do this. But anyway, just a little joke there. Moving on. So what are our strategies to reduce multiple pregnancies when using ART? As I said, the most common treatment was the low-tech, and unfortunately the most common source of multiple births is probably from ovulation induction medications, not IVF. Unfortunately, Bourne will not have this data in it to look at this particular issue or study it because we're not going to be at this point doing our low-tech treatment. And some of these treatments, of course, don't occur in an IVF or fertility clinic, but outside in a family doctor's office who may be prescribing clomiphene to his or her patient. But in the future, maybe this will be an additional thing we can add to the Bourne database once we get the IVF database perfected. The problem here, of course, is the lack of control over the number of embryos that fertilize or implant. How can we lower the risk of multiple birth with ovulation induction? Using lower doses, but that doesn't always work in many patients because they respond in a way that we don't always expect. They over-respond. We can convert these cases to IVF when there's too many eggs being produced, but there are cost issues of doing that, and some patients it's not affordable to go to IVF. We can selectively reduce embryo down to 1 or 2 fetuses maximum. There are multiple, high-order multiple. Of course, there are ethical issues with that. And we can cancel the cycle, but we can always tell the patient not to do anything and have intercourse, but that we can't always control that, what happens at home. So this is a difficult area for us in terms of reducing multiple birth. With IVF, I think we have more control because we can transfer as many embryos as we want to reduce the risk of multiple pregnancies, but we know that the less embryos we transfer, the lower the pregnancy rate. So the dilemma is the doctor preference, the preference that we reduce the risk of multiple pregnancy versus the patient desire, right? The patient in most provinces in Ontario, in Canada, all 9 out of 10, is paying for the procedure, which can cost quite a bit of money, thousands of dollars, and they sometimes feel they have the right to have what they want based on the fact that they're paying for it. When it's government funded, of course, we can then control what's being done more in terms of how we fund things, and we can fund based on doing single embryo transfer, which is how it works in Quebec. So there are very strict guidelines for coverage. So our strategies, of course, are transferring less embryos and, of course, better embryo selection, because if we have a lower pregnancy rate, that's not as desirable for patients, and doing better culture systems. So blastocyst is one way to select embryos, by those embryos that survive to blastocyst, as well as improving other ways of improving selection of embryos, improving cryopreservation so that if the pregnancy does not occur or if they want another child, if we have better cryopreservation, we can have better pregnancy rates with lower numbers of embryos transferred. And selective reduction, as I mentioned before, is an option when too many babies are implant in the uterus. The problem with this whole area, as I mentioned, is that patient acceptance when they're paying for it is not always there. They feel that they have the right to do some, even though there is an increase, that they know and they're informed there's an increased risk of multiple pregnancy. the desire for twins. Sometimes I'll tell a patient, well, you know, there's a risk of twins here, and they'll say, wow, where do I sign up? I can have my whole family at one time. I'm 39 years old. I don't know if I'll be able to conceive again when I'm 42 when I want a second child. So this is one of the issues that becomes becomes difficult for us when counseling patients. And even when patients are given very detailed information about the risk, they still sometimes would prefer to put more embryos in and have an increased rate of twins and have their family at one time. So this is one of the issues and why there still, I think, is a higher rate of multiple births still with IVF, but there is an improvement in the trend, and I think with the funding in Quebec and hopefully across Canada, which we're all fighting for, this will not be as much of an issue in the future. We know that, you would think that putting more embryos in would increase the multiple pregnancy rate. This is the Carter database data for 2010. Well, the only strategy that really reduced multiple pregnancy is using one embryo to transfer, single embryo transfer. Putting more embryos in the Carter database did not counterintuitively increase pregnancy rate, and the reason really for this is because REI specialists don't put in 4 embryos, hopefully across Canada, when they know that the embryo when there's good embryo quality or younger patients. So these are really the older patients who have poor embryo quality, and their chance of success is much, much lower, and therefore putting more embryos in doesn't significantly increase the rate of multiple pregnancy in most cases, yet you still can achieve pregnancy. So this is the strategy we sometimes have to use in terms of improving pregnancy rate. However, if we were able to select out those embryos better that could make it to a baby, and there are some strategies that I'll talk about that we could possibly do to increase our selection. Luckily, there has been an increase in single embryo transfer across Canada. This shows the trend across Canada, and you can see from 2009 to 2010, which mainly is the Quebec influence to some degree. There is some increase in other provinces, but Quebec has led the way with their government funding. So single embryo transfer has increased, and this has, as on the next slide, resulted in a lower rate of multiple pregnancy across Canada. The rate was hovering around a too high rate of 30% across Canada, but now has come down to about 25% across Canada overall, and much lower in Quebec if we take that data alone. And in the rate of high-order multiple pregnancies, triplets, and so on, has also gone down over time. So this is good news for Canada in terms of our rate of twins, but we're still not a multiple pregnancy, but we're still not there yet. One of the other reasons that the ways that we've achieved this single embryo transfer and improve the rate of pregnancy with single embryo transfer is to go to blastocyst transfer. So the rate of blastocyst transfer, which is day 5 shown here in green, has increased over time, especially in the last number of years. And the next slide shows just the proportion of day 5 transfer that has increased over time using the Carter database as it is. So there are more day 5 transfers. Now, of course, there may be a price to pay for this, and that's what I'm going to be talking today about in terms of this data that we've shown. And we have to think about other issues that may occur by culturing embryos longer in vitro. So what are the advantages of blastocyst transfer? Higher implantation rate, opportunity to select the most viable embryo, increased single embryo transfer pregnancy rate because of pre-selection of embryos that make it, better synchronization between the embryo and the endometrium because of the time of transfer, the uterus is better prepared, and it also is the best stage for doing another technique that may also improve in some cases pregnancy rates by doing pre-implantation genetic screening, which now is becoming more and more available for patients to screen for embryos that do not have these abnormalities that we see in the older women. The disadvantages are that there are less frozen embryos left, so for baby number 2, 3, or another try if it's not successful, there are less embryos left. We don't know if the embryos that don't make it through day 3 to 5, if all of them wouldn't have made it inside somebody's uterus in a natural environment, because of course it is an in vitro artificial environment, and basically that can't be as perfected as the natural environment. There is a higher also risk of a canceled cycle, so sometimes absolutely no embryos make it to day 5, so this can be psychologically very difficult for patients who have absolutely no embryos to show or even transfer and have no chance of a pregnancy at all before they even got an embryo transfer. So this is a very difficult situation for the doctor and the patient to deal with, and a lot of times when we have fewer embryos, we're not going to take the risk of transferring, going to day 5 and losing all the embryos and saying, okay, well, let's put them in on day 3 and at least we'll have some chance of success, because we don't know if they had been lost, they would not have worked inside someone's uterus. And the other possible disadvantage is the issue of perinatal outcome, which we're going to talk about in a second. So recently, I started to notice studies that came out, and this is a study that came out in 2010 that showed that when embryos were transferred, and this from Sweden, that embryos were transferred from blastocyst versus cleavage stages in vitro, there may be a difference in neonatal outcome. Of course, we were trying to achieve lower multiple birth rates. So, of course, if there's a multiple birth, that of course would increase the risk of poor outcome. But when we look at singletons after blastocyst versus cleavage stage, in the Swedish study, which is a large number of patients, there was more preterm birth among singletons after the blastocyst, and also they found that there was an increased risk of congenital malformations. So this was noticed when they looked at their database. In Sweden, the next slide shows their table from that study, which shows the odds ratio of a premature birth, and these are the late preterm births that were increased, and the odds ratio was 1.35, which was significant. And also they found that there was but they did not find, an increase in low birth weight. So this is interesting that they found an increase in late preterm birth, but not an increase in low birth weight. So the thinking was there more growth restriction with the cleavage stage, or was there more large for gestational age with the blastocyst? So this is one of the questions that we have to answer to explain this discrepancy. The other thing they found looking near the bottom of this table was that the odds ratio of a severe malformation was increased, and sorry, the circle there is around the wrong one. Any congenital malformation as well as severe malformation were significantly increased in this particular study when blastocyst transfer was compared to cleavage stage transfer. The next study that came out was last year from the U.S. SART database, which is even much larger, and this data came out last year, and it showed again that there is an increased risk of late preterm delivery in their data with blastocyst transfer versus cleavage stage, but they also found in their database, which was much larger, a significantly increase in very preterm birth. So this study showed a difference, even though it was 2.2 versus 2.8, a small relative difference, but significantly different rate of very preterm birth with blastocyst singleton births versus cleavage stage singleton births. They did not, unlike the Swedish study, did not find a difference in congenital malformations, so that was a difference between the two studies in terms of their data. It's not shown on this slide, but that's on another table. So we have a very, very large cohort here, 2 studies from 2 different countries showing very similar data. So we felt, hey, this is the time we should look at the Canadian data from our own data. They also did not find, interestingly, a difference in the low birth weight, which was similar, that they found the late preterm was increased, but not a difference in the low birth weight. Although it's close to significance, it did not reach significance there. Again, there may be differences in LGA and small for gestational babies that could explain that. They did not find, they didn't find a difference, interestingly, when they looked, there was a difference. In addition, they were able to look at preterm delivery in twins with blastocyst transfer and very preterm delivery with twins. And interestingly, there was an increased rate of preterm birth with twins with blastocyst versus twins from cleavage stage. So again, there may be an increased risk not only with singleton births, but twin births that are derived from blastocyst transfer as well. So this data, they were not able to show this in the Swedish data, but this was something else that they found of interest in the U.S. data. So we looked at the same data in the Canadian Carter database, and we were able to do this, and this is now in press in the journal Human Reproduction. So I'll show you the data that we were able to derive from the Carter database, which was limited, but we were able to get some interesting data. So our data came from 2001 to 2009. We included all fresh IVF ICSI cycles where one infant was born, including stillbirths at greater than 20 weeks. Embryo transfer was, as I said, day 3 or cleavage stage versus blastocyst. And exclusion, we didn't look at twins or egg donor cycles in this particular study. The total number of cycles was over 12,000, almost 13,000 cycles looked at during that 9-year period. The outcomes available for analysis were preterm birth, very preterm birth, low birth weight, very low birth weight, congenital anomalies, stillbirths, and neonatal deaths. We adjusted in our sub-analysis because we know there are factors that could have contributed to differences between the cleavage versus blastocyst. For example, changes in culture systems over the years may have contributed, so we looked at the year of treatment. We looked at maternal age as a cofactor. For the sub-analysis, we looked at the parity. We looked at the infertility diagnostic category. We looked at, we corrected for the number of embryos that were retrieved. That may be a marker for polycystic ovary syndrome, and those patients may have differences in outcome. We looked at the fertilization method, the number of embryos transferred, 1, 2, or 3, that resulted in that singleton pregnancy. And we also looked at an important factor that has come to be realized that affects prematurity, which is the vanishing twin, because even a singleton birth, when there was a second fetus that implanted, may increase, has been shown in some studies to increase the risk of prematurity. So this was important to correct for, to make sure this wasn't the reason for our differences that we may show. Our findings overall was that there, again, interestingly, 3 different countries, same result. That early preterm birth was increased significantly between blastocyst transfer and day 3 transfer. We did not find a difference, significant difference, in the very preterm birth, but you can see here that the numbers are much, much lower, and so probably this would reach significance or could reach significance if our numbers were as high as the U.S. database. We did not find a difference in low birth weight or very low birth weight between the 2 groups, again confirming that it's the prematurity but not the birth weight that seems to be different. And we are unable to look in our database, I'll talk about in a second, at the LGA-SGA question, which I think is important to explain this particular discrepancy. We did not find a difference in congenital anomalies. We did, stillbirths are very low numbers, but there was no difference. And neonatal death, again, low numbers, but no difference. Again, we adjusted our findings for all the risks that I've mentioned previously, and even after adjustment, the late preterm births were significantly different. The early preterm births did not reach significance in this analysis, again confirming the same and findings of the other two studies that have been published. So in discussion, the CARTA database birth weight input was a problem with it is that it's entered in weight ranges rather than specific weights. So therefore, the effects that we see with our CARTA database on birth weight are not as accurate. We hope that the BORN database will be able to much more accurately look at this question. The fact that we noticed a higher rate of preterm birth with blastocysts without differences in birth weight suggests the potential for a higher rate of large for gestational age with blastocysts or a higher rate of small for gestational age with cleavage stage embryos, yet to be determined. This could not be calculated with our CARTA database, and again, we hope BORN will be able to give us the answer to this question. What is the potential significance of an increase in late preterm birth? Very important question. Well, we know from data that late preterm birth does affect outcome, both short-term and long-term. It's been shown that there's increased risk of neonatal death, respiratory complications, hypoglycemia, newborn sepsis, and admission to neonatal intensive care. Of course, these risks are much lower than the very preterm birth, as we all know, but they are significantly increased even in late preterm birth. As well, there are long-term effects that have been studied, and there are increased rates of behavioral problems in late preterm birth. There's a lower IQ at the age of 6 that's been shown in late preterm birth, and this was independent of maternal IQ, residential setting, socioeconomics, and this was from a study by Talgay in 2010. So we know in most studies that there are significant effects of late preterm birth. So this difference in between the blastocyst versus cleavage stage may have important implications for the outcome of the children. What's the hypothesis for why this may happen? Extended culture may adversely affect implantation and placentation for some reason. There are potential genetic or epigenetic effects on the placental tissue that may affect when labor may be initiated. The type of media solution and in vitro culture itself has been shown that it may cause changes in embryos from a study by Risos in 2002. The cultural effect on embryos from in vitro animal studies there's been shown to be effects on the transcripts of various genes for apoptosis and a gap junction gene called CX43, and there have been changes in animal studies in placental morphology. There are decreases in intravillous volume density, binucleate cell volume density in bovine embryos that were cultured compared to in vivo embryos. So we know that extended culture may have an effect on other outcomes later on, so it makes sense from a biological plausibility point of view. The potential solutions for this in the future may be improvements in vitro culture media and incubation systems to reduce the risk of extended culture to blastocysts. I think we have improvements in the last few years, but I think we have far to go with this. Also, the other potential way is to avoid long culture. In other words, improve selection of embryos, because all embryos that reach blastocysts had to be a cleavage stage embryo at some point. So if we can select cleavage stage embryos better by some mechanism, either by protein, genetics, or metabolomics, these are huge areas of research going on in fertility, then we may not need to do extended culture of embryos to the blastocyst for better selection. So I think how could BORN help? Well, I think BORN can really help in terms of to find out why there's no increase in low birth weight, as I mentioned before, in the presence of increased prematurity. It can help us to also look at other issues like BMI. This was not something we could look at in our database, and hopefully BORN and you guys can tell me whether this kind of data can be derived from born and may sort this out. And finally, we can determine whether the differences we and others have observed could actually translate into long and short-term effects on the offspring in our Canadian IVF programs. So I think we're at the beginning for this born database, and I think there's a lot of potential, and this is one very interesting and exciting area where we could learn a lot. So I'm going to stop there, and I think we can entertain questions.
Thank you.
Thanks so much. Thanks so much, Cliff. It's Sandy Dunn speaking. I'm the Knowledge Translation Specialist for Born Ontario, and I'll just help to facilitate some of the question period with John, who's our helper from Arcaden online. I'll just let you know you can either type in your questions in the chat box on the upper left part of your screen, or you can call in, press 01 to add your name to the chat, to the call-in list queue, or 02 to remove your name, and we'll get John to monitor the call-in queue, and we'll just give it a minute to see if anyone has any questions. Don't forget you can type in your question or use the telephone call-in line. Are there any questions on the line for us, John?
I'm showing no questions at this time.
Okay. Oh, Anne Sprague is here, and she just asked me to mention that Born has BMI data being entered into the information system as of April 1st of 2012, so that will be very useful information, as you've mentioned, Cliff, to look forward to exploring some of the implications with
Will that be BMI from the IVF database, or would that, I guess BMI at pregnancy wouldn't probably be useful?
We will have BMI, so when a woman comes in labor, she's asked about her weight prior to pregnancy and height, and a BMI is calculated. As well, we also have weight gain during pregnancy because we ask about current weight. So we can calculate both of those things, which will be useful to you. We can link it back then, at least in Ontario, to the data that comes into the system.
Oh, that's great.
I see a question here in the chat box. And it's Moya who's just actually making the comment that I just can't move the chat box here. There we go. BMI will be included in the Carter Plus data.
Okay.
There's a second question here. Is there any software or funding for software available for individual fertility clinics? Cliff.
Moya can answer that one.
Or Moya.
I'll let Moya answer that one.
Okay. Are you online there, Moya?
Moya may not be logged in as a moderator, which she needs to do in order to answer questions.
Well, I can tell you from our own experience that each of the clinics has different current databases that they've been using to enter data from Carter. Those databases are now expanded with many more fields. I was part of some of the group looking at increasing the fields. A number of us across Canada did that, and this is an important issue so that we can increase the amount of data that can go into the fertility database part of this, and we'll be able to hopefully get much more data that can then be linked up to the Born database.
So for whoever had the question about software, it would be best if you contact Moya Johnson, who is the fertility subject matter expert here at Born. If you contact her directly, and her contact information would be on the Born website, but if you contact her directly, she'll get back to you about that particular question.
I'll just check with John for a second, see if there's any calls coming into the telephone queue.
I'm showing no questions at this time.
Okay, thanks, John. Moya Johnson has just posted a comment. Carter Plus has greatly expanded the data elements that have been previously collected. I had a question, Cliff. I just wondered if there is any information available about the reasons for preterm births from the perspective of, are these all, do we know if preterm labor is just more prevalent with these cases, or is there a reason for preterm delivery to have been occurred because of some sort of issue with the fetus? Is there, or is that something that
so
needs to be explored?
preterm, I think Mark could also discuss this as well, but I mean, preterm delivery is a huge area of research in perinatology, learning why people deliver early. In regards to the question that we're looking at, what our theory is that could this extended culture affect the cells that are around? Remember, we showed that blastocyst and the cells that are around the edge that make what are called the trophectoderm, or that will eventually become a placenta. If those cells are exposed to this culture system for longer, maybe oxygen radicals or other types of negative influences on the cells, may then affect the ability for the placenta to form properly. We call that placentation. And the placenta is very, very important in terms of determining when labor may occur. And so it's possible that the placental development is affected from this very, very early stage, which I think is very, very interesting. Very few people would have thought that an early stage event like that could actually affect a pregnancy so late in the gestation. Mark, I don't know if you have any other comments as well.
Actually, Mark had to step away, Cliff. He's not able to be here right now, so we'll have to follow up with him about that. Are there any other questions? Don't forget, you can call in to the phone queue by punching 01 on your phone dial, or you can type a question into the chat box, the upper left-hand corner of your screen. If you have any questions, this has been a wonderful, wonderful overview and presentation of amazing information, and it is very exciting to think about the potential knowledge that we can that will be generated, that we can learn more about the outcomes and implications of different kinds of infertility treatments.
It's Ann Sprague from Bourne. I just also want to say, I think when we see how the data is being used, it's really important. I mean, I think that speaks to the importance of data quality within the system. And, you know, for all those folks that are really working hard to enter data, we really, really appreciate it. And I think that this is, you know, when you see how the data is being used for research and how it can be used to make decisions about care, it really speaks to the importance of data quality. So a good thanks to all those folks that are entering data for Bourne.
Absolutely. I think it also it speaks to the fact that it'd be nice in the future that we could get data from other provinces as well, because of course we'll be limited to Ontario, and that, you know, the more data that we have, the more we're able to find differences that are significant, because power of this of finding things is obviously going to be related to how much data that we can accumulate.
Mm-hmm. There's no more questions in the chat box queue. John, I'll check with you one last time. Are there any phone-in questions?
We have no audio questions at this time.
Okay, thank you. Well, we're just a few minutes early, but if we have no more questions, then I think probably we'll go ahead and sign off a few minutes early. And on behalf of Bourne, Ontario, I would like to thank Dr. Lebrac for spending the hour with us and presenting a wonderful overview of this topic, very informative, wonderful slides and explanations. I certainly learned a lot, that's for sure. So,
it was a pleasure. Thank you.
Thank you very much, Cliff, and thank you for all the work you did in preparing the talk. We appreciate it. Thank you to everybody. Thanks, everybody.
Looking forward to a very exciting future with Born.
And Born is too.
Goodbye.
Thanks to everyone for joining us, and we will see you next month at the next Born Provincial Round. Stay tuned for the announcement. Bye now.